Sorry, technical difficulty. We're just going to recap what we just said while the rest of you join back on again. Sorry about that. I'm speaking with Dr. Crawford live from University of Maryland Medical Center. We've just been reviewing the importance of follow-up care, and we've been discussing that it is very important to closing something. It is very important to follow up with your cardiologist, your primary care physician, your surgeon, and then maybe even possibly a vascular surgeon, depending upon how your dissection is, how long it is, where it is in your body. So those are all things that you should consider. I apologize ahead of time if we bump off again. Again, this is my first time doing this, so we're trying our best. But getting back to our questions, we were just asking you about CAT scan versus MRI. And I know for myself, I dissected the end of January 2015, and I would probably say in my first 12 months, I must have had maybe five at least CAT scans, which is a lot. So is there a preference or a reason why one might have an MRI versus a CAT scan?
I think that for patients that have not had interventions with endovascular stents, which follow-up with MRI is very difficult because of scatter and some interference from the stents with the MRI. Not necessarily that they move, but the image is not acquired appropriately. MRI is beginning to, I would say, take over, but certainly appear as a viable alternative for CAT scans for the follow-up of patients with aortic dissections. In fact, there are certain techniques that you can use in MRI that give you additional information. These are only obtained or typically obtained in centers that have experience in looking at these MRIs, and usually patients have had previous CAT scans for comparison. I think it's a very important point. Patients with dissections are going to have repeated imaging throughout their lives, and it's not just the accumulation of the radiation, which may be a concern, but also the dye that's given to the patients in order to be able to get a good study. The cumulative dose of that dye really hurts the kidneys of a patient that already might be compromised because of high blood pressure. For example, this might cause them to eventually maybe potentially go into renal failure, or at least accelerate the appearance of renal failure. I think if you have a center, and the specialized centers do offer MRIs, if you go to a specialized center, you should definitely ask for an MRI. Some people don't prefer the MRIs because of how they are closed, and we do need high quality MRIs. You know, a bad imaging study is as good as no imaging study. You know, I think this is something that is going to take over in the future. More people are going to be having routine MRIs unless they've had an endovascular stent. And even for those, the techniques might get good enough for those to be a possibility. Avoid the radiation, and in a lot of ways, avoid the contrast.
And I'm so glad that I asked you that question, because for me personally, I'm allergic to the contrast, so I need to prep with prednisone, I need to prep with a lot of Benadryl, and then it just feels terrible, and I keep thinking I'm having 120 shots of x-rays at each time. So it's nice to know that I could just ask for the MRI because I don't have any stents.
Now the MRI does come with a form of contrast.
Okay.
It's called gadolinium. However, there are new techniques that are being developed for contrast to be or for the images to be obtained without contrast.
Okay.
I think that this is something where things are moving in the future. It's an area of active research that I see at every conference. There's always a couple of talks about new uses of MRI, and I think that's something that, as a patient, you should be asking, your doctor about. Hey, do you think you could get me an MRI? What do we do about that instead of getting a CAT scan?
Okay, I'm just taking some notes on some questions that we're getting, and we'll be ready to get to questions in just a minute. So if I don't hit your question, just ask it again. But cardiac rehab, I'm actually very surprised to find out that there are some patients out there that don't go to cardiac rehab. They don't know, they don't understand the importance, and believe me, for me, I did it, and it was 12 weeks, 3 times a week. And I think what was most fascinating about the rehab is I started off with a minute walking very slowly on the treadmill, And I think in recovery of open heart surgery especially, it's very difficult to see and feel that you're recovering. Time just seems to stand still. You're a hamster on a wheel. And when you leave cardiac rehab, I think it's twofold. I think it shows you physically that you're improving, and emotionally and mentally, it gives you some sense of security. So I just wanted to know your thoughts on cardiac rehab as follow-up care.
I mean, I think that we typically say a week outside the hospital for every day that you spend in the hospital before you start feeling normal.
Okay.
I mean, that's typically, a kind of a rule of thumb.
Mm-hmm.
And obviously, any kind of rehab that you're able to do, it helps with that. There are a multitude of things that probably impact your ability to recover. If you've had a procedure, just going under anesthesia, being on a ventilator, is something that's going to give you a little bit of a hit in terms of being able to recover quickly. And this has borne out in many other diseases, not just in aortic dissection. Obviously, a big dissection can cause pleural effusions and can cause problems in the thoracic cavity. Can give you fluid in the lungs. Again, this is going to make you probably not feel as optimal. Then we throw all these medications on top of you, beta blockers specifically, that sometimes can, kind of hit you a little bit in terms of your ability to have enough energy. So I think if you can do it, I think it's very important, very valuable. There's nothing to lose by doing it, and I think that if you can do it, you should definitely take full advantage.
And it's usually, I think, covered by insurance, correct?
It usually is. I think it's very state dependent. Obviously, not everybody's gonna get covered, depending on the insurance you have. But I think it's something that you can certainly explore as you get out of the hospital. There's a certain amount of incidence of, at least with cardiac cases, not necessarily dissection, incidence of probably some depression in patients, or feeling of depression, clinical depression for patients post these types of situations, PTSD. And obviously, being in a rehab program will help you deal with these issues.
For those of you who have not been in rehab, it's not just about the physical. At least in mine, there was education once a week. We were either learning about nutrition, the importance of stopping smoking, the importance of just continuing exercise on your own, some mindfulness. So it really covered a lot of different things in cardiac rehab than just the physical aspect. Getting to blood pressure, you had mentioned how a lot of patients struggle in maintaining their blood pressure, which my understanding would be that 120 and below for the systolic. So I myself have had struggles, whether it's just I'm still struggling or it's because I have Crohn's as well. And I recently had the 24-hour BP monitor. So I'm curious to know your thoughts. When I got the results back from that BP monitor, I was quite stunned, which then my blood pressure went back up from anxiety to find out that I had been running pretty high, 140s, 150s, 160s. With all my meds. And as beneficial as it was, I guess I just want to know your thought process. Is this something that every patient should do? Because we don't want to be tied to our cuffs, which we are. Whenever you finish surgery, you tend to be tied to your cuff for a while. It becomes a piece of jewelry. So how often should we be checking immediately after surgery, maybe 6 months later? And at what point do you really say, I think maybe I need to be monitored freely?
Yeah, I think initially is probably the most important part, because I think initially there's going to be the most variation. Like I said, patients get in the hospital during the acute period with very high blood pressures. They get on medication. The most typical pattern is that patients go home outside of the stress of the hospital, and sometimes they can be under medicated. Some patients have hypertension, it's more and more difficult to control and need more medication. So that initial period, I think, is very important, because you don't really know how you're going to react once you get out of the hospital. We have been trying for at least the last year to start a project where we have a more automated way of trying to check for blood pressure from our patients. So I think the initial period is very important. I think in that you learn about what your blood pressure does on a daily basis and how it reacts. Then I would say that once after you get to a stable period, we've been out of the hospital, you got a stable regimen. And another thing that I would say is that most places that have a serious aortic dissection program will have somebody that only deals with this, and we have Wallace that basically follows everybody intensively and is very experienced and essentially only deals with the hypertension issues. After a while, I think that you're going to see that there's going to be some ups and downs, and I think it's normal variation.
Mm-hmm.
There are times in which your blood pressure is going to be 140, 150, but I think that initial period is the one where you should really pay attention until you get into kind of a zone where things are a little bit more stable.
Okay. Before we go to questions, I'm going to actually take this from you because I can't read the questions that far away because I'm much older now. I guess I just wanted to know, is there anything you want to say in summary about follow-up care?
Well, I think I keep telling my patients when they come in and they show up that they're with me for life. I mean, that's really how it is. That I think follow-up care must be consistent, that you have to be diligent. I think this is something that you're going to have forever, and I think you should treat it as such. And I think if you're consistent and you're plugged into a good system, I think that's the best way. That's the best way to handle it. Be responsible, be proactive, but also be able to be in a place where all the tools are there to be able to take care of you. I think that's what's important about follow-up.
Okay. All right. I think we are ready to open it up to some questions. Let me see if I can scroll back and see what we've gotten so far and see if we can address any of these. So we have a question from Andre that says, why are some patients released with lifting restrictions and some are not? Try to keep your questions, just moving forward, as much as we can to anything related to follow-up care. So why are some patients released with lifting restrictions and others are not?
Obviously, if you, and you'll learn this when you follow your blood pressure, that lifting heavy weights can cause a peak in your systolic blood pressure. It gets quite high. You get on the treadmill, your blood pressure goes up and your heart rate goes up. So I think the lifting restrictions only is part of a way to try to limit how your blood pressure goes up and down. Sometimes these peaks in blood pressure can cause additional tears in the aorta, or can exacerbate a tear and cause further problems. So it's all about trying to keep this, the blood pressure at a reasonable level to prevent not only further complications, but on the long term degeneration of the aorta, and then the appearance of aneurysms, aortic aneurysms, which is something that is prevalent in that population.
Okay. Kathy asks, what is the recovery time after repair? And I know that's going to differ from patient to patient.
Really depends on the repair. For a type A dissection, I think patients typically are in the ICU maybe for a few days, 2 3 days, 4 days. Best case scenario, maybe they're out on the floor up a week or so, 10 days, and then some of them actually end up going home. Then comes the post-op care, which can be sometimes challenging because of all the reasons that we have talked about. For type B dissections, if patients require repair, now most of these are done with endovascular stent grafts. Probably around the same time, probably a little less. Some of the recovery and some of the issues in the hospital don't necessarily have to do with the surgery, but have to do with getting the patient on the right medication and ready for discharge after the surgery. So we'll spend, we'll take a patient to the operating room with an acute type B dissection, put a stent in, they'll be in the ICU for a couple of days, and then the patient will be okay, but it might take us a few days to fine-tune that blood pressure regimen in order to get it to a place where we feel that the patient is safe to get out of the hospital. So the recovery is not only a recovery from the surgery, but a preparation to get out of the hospital, in this new life, in this new dissection sort of reality that you're going to live in, where you have to watch your blood pressure and you have to be mindful of all these medications that you're taking and where to follow up and all those things.
Right. That's a lot. That's a whole new life. So Lori asks, how long do the twinges of pain above the breastbone or the breast last post-surgery? I know that might be different for everybody as well.
Yeah, I think it really depends on whether you've had an open repair or an endovascular repair. I mean, I think that some patients have that for a long time. I've had some patients that come in and tell me that they've had them, for months and months and months, and they really never go away. They kind of learn to live with them. Some of them have them, and then they go away. It's kind of, I think it's different for every patient. The idea is that you come in, you do your follow-ups, you have the appropriate imaging, your blood pressure is under control, and that you're reassured that some of these things that are bothering you are not something more serious. Because I think that's the anxiety that the dissection patient lives in. It's like, oh my God, I have this pain. Is this going to turn into what it turned into last time?
Right.
And I see that fear in their face and their eyes about this. And that's why you need the follow-up, the appropriate follow-up in the imaging to know that things are stable.
As aortic root enlarges, does BP elevate?
Not necessarily. Actually, it may be quite the opposite. I don't think that there's a linear relationship between that, and also it depends on whether there is valvular involvement or not. But that would be more of a question for Dr. Taylor to ask. But there's not really a direct relationship in that.
Here's a question, and I hear this often. Angie asks, I've been recently diagnosed with a 4.4 centimeter aortic root. Do you have any advice? Doctor says once it reaches 5, then she would operate. And a lot of people are afraid to ask any questions, and they're afraid just to live their everyday life because you're just waiting for it to hit number 5. And why 5? Why not 4.5?
I think I think it's important once it gets to 4.4 or close to 4 for those aneurysms that you not only be under the care of a cardiologist or internal medicine specialist, but you'll be seeing your cardiac surgeon in this case for the aortic root aneurysm on a regular basis. There are features of aneurysms that would make me operate on an aneurysm a little bit when it's a little bit smaller. The thing about the size is we know from natural history data approximately at what size the risk of rupture for aneurysms gets too high to be safe. And when the risk of rupture exceeds the risk of the repair, that's when we start thinking about offering a repair to a patient. So, for example, for an abdominal aortic aneurysm, the number is 5.5. Why 5.5? Well, because at 5.5, the risk of rupture for an abdominal aortic aneurysm is somewhere between 5% or so, 5 to 8%. The risk of repair is probably much less than that. It's like 2%. So it favors fixing it versus letting it go. Whereas when the aneurysm is 4.4, the risk of rupture is probably 1%. So in essence, the risk of actually fixing it is much higher than the risk of leaving it alone. So although you might say, well, if it's 4.4, why don't we fix it? We don't fix it because the risk of fixing it is greater. And we have done those experiments for aneurysms, not in the thoracic aorta, but in the abdominal aorta. We have done an arm where we fix aneurysms early, and we fix aneurysms at what we consider the appropriate size. And fixing the aneurysms early has not been shown to offer any mortality benefit for any patients. So you don't do any better if we fix your aneurysm earlier. So why take the risk?
Do you have any change of lifestyle for that person? If you find that somebody has a 4.4, are you more inclined to tell them not to be as active? Or is it really just a lot of managing your blood pressure and just go live your life?
I think that's probably the best case, what I tell most of my patients.
Yeah, just go live your life.
Live your life, manage your blood pressure as
you guys manage the rest.
we
think about the rest.
We catch you when you're ready, when things are ready to fix.
A couple other questions here. Whitney asks, migraine headaches common after surgery. I know I'm having what I thought were migraines, but turn out to be ocular migraines.
Yeah, I don't know that there's a specific connection. Migraines are a specific type of headaches. I'm not a headache specialist, but migraines are a specific type of specialist that are headaches that come with specific other symptoms, auras and whatnot, a constellation of symptoms that are not necessarily related to aortic dissections. Because patients have headaches, yes, they can have headaches, but it might be related to the hypertension, not necessarily because
or
of
to
the
maybe your
dissection.
medications. Some medications can do that.
Or perhaps, you can have headaches or you can have lightheadedness. I think you go in a different spectrum.
Right. Okay. Marilyn asks, I'm assuming, Marilyn, that maybe you had open heart surgery. Is there a time limit that she should wait before having a mammogram?
A mammogram, no. A mammogram is an ultrasound. and there's really no restriction. I think you should follow your appropriate schedule that's recommended by, your oncologist. If you need to have a mammogram because you're due for a mammogram, have your mammogram.
Okay.
Obviously, if you have a fresh incision, you be mindful of that. But
Right.
other than that, there's no restriction.
And I'll just say, if you've not had your first mammogram since your surgery, I had one within the first year, maybe within the first 6 months, and it was not uncomfortable. Actually, they worked. They're pretty familiar and they're pretty gentle, and they know to work with you in that situation, and they'll just go slowly to whatever your comfort level is. So getting back to the operating or not operating, a specific question is being asked here. If you have a 4.5 centimeter aneurysm, why wouldn't you operate on a younger person rather than 5 centimeters when they're older? Does age have anything to do with it, or it's strictly just this size?
It's really strictly size. Although, and I think there's no specific indications to operate on younger people who have smaller aneurysms.
Okay.
Again, we don't see any benefit. It sort of intuitively makes sense. You're young, you're going to have this aneurysm. Why not fix it now? There are times in which patients' anxiety level just goes too high, and maybe we fix an aneurysm at 5.5 or at 5, and then maybe we schedule them at 4.8 and say, okay, we're going to do your aneurysm. But there's really not a defined indication or any studies that show any benefit for fixing aneurysms that are smaller. The only group of patients in which we may fix aneurysms that are smaller by size are smaller people. A 4.4 aneurysm in a patient who is 5'2" and 120 pounds is not the same as a 5'5" aneurysm in somebody who is 6'3" and 260 pounds. It's much more dangerous in the smaller person. So proportionally, an aneurysm of the same size is more dangerous in the smaller person.
And what are we talking about as far as, because I have no idea what that looks like. I mean, I look at it when it's on a measuring stick, but what are we talking about?
So 2 inches.
Okay, so it's about 2 inches.
2
That's
inches.
a big bulge.
2 inches is 5 centimeters.
Okay, that's pretty big.
Yeah.
Okay. Do dissections ever actually heal? Not spontaneously on their own, I would think, right?
Dissections, yes. The answer is yes. There are certain types of dissections that can actually heal. Members of the dissection family, such as intramural hematomas. Sometimes these small tears in the aorta can actually heal with good blood pressure control. Full-blown dissections don't tend to heal. They tend to stabilize, I would say.
Okay.
For the most part. And, the idea that that's just going to go away, I think, creates a confusion because I think it gets in the way of the most important thing, which is appropriate follow-up.
Okay.
When we say that, your dissection looks good or your dissection looks like it's, stable, we don't mean that dissection is actually getting better. There's been an architectural anatomical distortion that's not going to resolve there.
Right.
But it can sort of stay the same.
Okay.
If you have a very small, sometimes people get very small tears in the aorta that cause blood along the wall of the aorta. With good blood pressure control in the appropriate patient that doesn't have other anatomical risk factors, high risk factors, that can heal. But that's a very small subset of dissections that most people don't have.
And when we get CAT scan results back, because I know a couple people on these support groups have been concerned when they read the word thrombosis. When they read that, they have thrombosed. If I'm saying it correctly, that's considered a good thing to have a blood clot in your false lumen.
That's correct.
Yes? Okay.
Thrombosis of the false lumen is a good sign. It means that either if it's done spontaneously or if it's done because somebody's placed a stent, it means that you've essentially diverted the flow back into what we call the true lumen or the actual lumen of the aorta, the good lumen, let's put it that way. So thrombosis of the false lumen is something that we look for when we repair aneurysms, especially endovascularly, and it's a sign that the repair has actually done its job.
Okay.
So
that's
yes,
a good thing.
So that's a
So
good
now
thing.
we don't have to worry.
Yeah.
Karen asks, any exercise guidelines post-open heart surgery for ascending aortic aneurysms with dissection in terms of blood pressure and heart rate?
I think that cardiac rehab is a great opportunity for being able to learn how to do that. I think everything in moderation actually is okay. I mean, in the end, you're not going to have any hard and fast restrictions. We don't want you to be a power lifter or take up wrestling. There's been people that have had aneurysms and have had serious aortic pathologies who have been back doing professional sports, who are doing competitive sports, who are doing triathlons and marathons and such, and they're doing quite well. I think the same guidelines that apply for people that are not doing exercise are going to apply for people that are doing exercise to sort of the same degree.
Good segue here, because my son asked a question that if there's a chance that there could be a genetic connection, he wants to know, should he have a concern about weightlifting restrictions? And I've had my doctor and his geneticist say that yes, maybe he shouldn't lift over 100, 125 pounds until we determine fully if there's a genetic, but he's asking you directly because he's sitting here.
Yeah, well, I think that there is a genetic component, and the genetic component has to do with problems with the tissue. To what extent that makes you more susceptible to an aortic dissection, for example, upon lifting, which means what the degree of penetrance is of that genetic component, is really not defined. I wouldn't feel comfortable telling a young man, say, you just can't do this forever. However, I do think that you have to be mindful that the real answer is that we don't know.
We don't know yet.
We don't know yet, and
right.
and I think with that in mind, maybe you think about taking up other sort of activities, or not pushing some limits.
Right.
But really we don't know specifically.
Just don't know yet. Okay, this is a good one. Carmen wants to know, does a woman with an abdominal dissection need to have precautions when having a pelvic exam when visiting her OBGYN?
No.
Okay. Good. Okay.
I mean, I think for regular exam, no. For abdominal aortic dissection, which probably is a continuation of thoracic aortic dissection, probably normal exams would be fine.
Okay. Let's see. Okay, it looks like we might actually be getting ready to wind down. So if you have any last minute questions, if I didn't get to something, please post it, because I know Dr. Crawford's probably very busy and has a lot to do this evening. But Meg wants to know, what is Dr. Crawford's hope for us and the future of the aorta community?
Well, I mean, I'm very committed to this, as I've made this my career, my life. I think that from a surgical standpoint, I can tell you that the future looks very bright. There's a lot of new devices and new technology out there to help when help is needed. I also have a very strong training in basic science and in epidemiology, and we are looking to see, for example, variations with regards to race and other factors that may affect aortic dissection, how different people react to it. And ultimately, this is a biological problem. This is a biological problem of a very big organ, which is the aorta. And I think that in the future, we hope to find molecular therapies and medicines that can either lower the risk of dissection, or when patients have a dissection, be able to control whether or not patients get degeneration into an aneurysm. I think that's what the ultimate hope is, and I think that this is a great area with a lot of research, and a lot of very smart people, myself not included, are very much doing a lot of work in this area, and I think that there's always new things coming out. The support systems are there. Places like, for example, like our center, where we have a bunch of people that are committed to it. I think you need to find that. I think that you need to have a comprehensive care and people that are totally dedicated to this problem, because it's not a trivial problem. It's a very serious problem. But I do think that the future is good. I think that there's a lot of therapies. I think that there's a lot of support. And I think people should be very optimistic.
When you were speaking about some of the latest and greatest, last time I was in here, I don't know if you can see this, there's a lot of devices on Dr. Crawford's shelf.
Yeah.
Do you care to go over just a couple of those and
Sure.
what they do? I'm not too sure how many of you have actually seen what your graft looks like or your stent looks like. So I'm going to show a couple of those now for you, and Dr. Crawford can go over those.
This is a standard. This is a standard graft, and this one doesn't have any branches, but this is one that would look like a graft that would go in an ascending aorta for an ascending repair. I guess it would be something like that, maybe. And so this is a Dacron graft. This is made of polyester.
So I would pretty much just do the arch.
This will do the arch, and some of these will have branches depending on how extensive the dissection is.
Okay.
Mostly for the ascending aorta. For the descending aorta, we probably don't use these anymore. These are the endovascular devices that we use now to treat the descending aorta. This is a graft made by Gore, and this Gore goes in the descending aorta. They come in various sizes. Here's two different sizes, a bigger one, a smaller one, depending on what your aorta looks like. This is made of PTFE, which is Gore-Tex.
Oh, it feels like plastic,
Yeah,
just in case you want to know.
It's the stuff that your shoes are made of and your jackets. And, these basically go in your descending thoracic aorta and, cover different lengths of the aorta depending on the tears. We're very excited because now there are new grafts coming into the market, endovascular grafts that are designed to treat other portions of the aorta and treat portions of the aorta that have branches. This is
That's pretty cool.
This is a new device that has a little branch that can go into the subclavian and can go into other portions of the aorta. And this is just coming out as a clinical trial. Will be here at the University of Maryland shortly. So we're very excited because this expands the possibility that we can treat a lot of the dissections with endovascular surgery as opposed to open surgery.
Mm-hmm.
So, a lot of these are coming out. There's some of these that obviously that I don't have that will be coming out soon that will allow us to treat the entire length of the aorta with an endovascular graft.
I do have one last question. Lifetime. What's the lifetime of these grafts?
The lifetime of these grafts, I think it is very good. We have data, for example, for these grafts, for this type of repair that maybe I would say goes, at least 10 to 15 years with very good results, and that's only because we've been putting it in for that long, and the quality of these grafts and the durability and the data of how long they last has continuously been upgraded. I mean, I'm holding a newer version of this particular graft, and only one company. There's other companies that make grafts that are similar, but there's obviously some older versions that may have not been as good, and these are have been tested and are the newest and the latest. And there's lots of improvement. This is an area of tremendous research, and there's multiple companies that do this, and there's all sorts of grafts coming out in the market every year, and things on the horizon. There's new things with new, more thinner materials with different branches that are made specifically so that it makes it easier to put them in people with different anatomies. So, again, it's good for dissection patients that this area is very active in research.
And so I have somebody said only 15 years. Gulp is what she said.
Well, I think that's only that we have data for. I
Okay.
mean, they probably the material is good for life. These grafts have actually not this particular one, but all of these have been put through testing where they put through testing in machines where they actually can move them at a certain frequency, and they'll simulate the movement of the aorta over the course of 40 years, but they do it in 3 months because they do it in a machine and they do it very quickly. So these have been tested for a very long time, and we just have data that runs that long because they've only been around that long. The first one of these grafts was actually implanted in the abdominal aorta in 1990, and that was a very crude version of that. I think most modern versions probably started around 2000 to 2005, and even these grafts are significantly better than the ones that were implanted at that time.
Dacron lifetime?
Dacron is lifetime.
That's lifetime.
It's definitely that lifetime.
Okay.
Yeah. And Dacron for the open repairs, we have data on open repairs that's very durable. We have data for that for long periods of time, decades. For endovascular devices, perhaps the data is not as long term yet, just because the technology is new.
Okay. All right. Okay, everybody. I think that's it. I think we did it. I think we got to our very first live event. Thank you so much, Dr. Crawford, for giving us your time and answering all these questions. And I hope you don't mind, but if we missed some questions, would you mind if we sent you an email list and you just answered them?
Actually,
that'd be great.
You can send an email.
Oh, you can send an email directly
Aorta
to Aorta
at SOM for School of Medicine
SOM School of Medicine
.umaryland.edu.
So Aorta at som.umaryland.edu. So if you have any questions that we don't get to, feel free to send an email directly to Dr. Crawford, and hopefully we'll have a chance to answer them. Thank you so much. Thanks for all your support and your questions. It was awesome, and I hope to talk to you soon. Take care. See ya. Bye.